Awesome information. I'm a 2-time breast cancer survivor. I used chemo and was clear. Then I started eating a lot of sugar and junk, and my scan came back with multiple spots on my lungs. I immediately changed my diet and fasted. My follow-up scan showed all the spots were gone. Thank you, Jesus, for this information. God bless you both. I could never fast for more than 2 days. But when I gave my life to Christ, I prayed and fasted against gluttony and could go for days fasting. Thank you, Jesus. I truly believe that fasting saved my life. I started OMAD 1/2019 and was 25 pounds down when I was diagnosed with breast cancer 3/2019. They took tissue samples, placed a marker in the area where the MRI showed a 1 centimeter and 3 centimeters mass. I continued to fast, walk daily, cut sugar. I had my mastectomy in May, and the pathology report showed no cancer around that marker. 4.5-year cancer-free. I 1,000% believe in fasting and will do it for the rest of my life.
Assumption, because we need to break out of it, because otherwise we are going to suffer. See, we are addicted because we've been made addicted. And then, of course, the medical profession, but also government forces have not really helped us because they've told us dietary advice that was not entirely correct. So we were told it was all fats, 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 fats. But now we know it's not all about fats. We know that it's also about sugar and carbohydrates and processed foods and what that does to us and changes our physiology. So, and these foods are addictive. So we've moved to a calorie-rich, addictive diet. And that's why addiction is such a huge part of everything I talk about to my patients. And I got to get them out of the addiction so that they can make changes in their life. So it's not just about just eat this, eat this, eat this. No, I have to recognize that these people are addicted. And this addiction is a serious addiction. It's as serious as being addicted to morphine or any other drug. And it's that serious. And people look at me and my patients look at me and say, you mean to say I'm a junkie? I said, yes, you're a junkie now. You really are. And I see it every day. I see it every day in my clinic. This is my clinic, and I run my practice every day. I do surgery. This morning I did angioplasty. I did a stent. So I'm a day-to-day cardiologist. And when I speak to my patients in the clinic in the afternoons, it's addiction. You know, one day, and they go, oh my God, I was breaking out in a sweat and I felt my sugar was getting low. So I had to go and eat and I felt better. And I said, and did you take your sugar level? And they said, yeah. And it was 100. Well, then it's not hypoglycemia. Pure addiction. It's pure addiction. So that's what's happening. We've moved away from eating real food to addictive substances. These are not foods, by the way. These are substances. So should we be consuming substance or should we be consuming real food? That's the issue. We're moving away from real food to substances, chemicals, addiction. And the combinations of these foods is also a problem. So you see, fasting is also about what type of food you look at the combinations. It's high sugar and high fat. And of course, there's lots of salt in it too. That combination is not found in nature. So when that gets into our body, it causes these hormonal changes. And the biggest hormonal problem I found was insulin. And I want to tell you a little bit about how I actually got into this.
Please.
Because ultimately, I'm just a cardiologist, right? So why is a cardiologist talking about dieting and sugar and weight and all these things? Well, you know, I've been doing angioplasty and stenting for over 35 years. So fortunately, you know, in London, I graduated as an MD at only age of 23. So I got into cardiology really early on. And I would do this amazing angioplasty. And some patients do great. Others keep coming back.
And sorry to interrupt. Could you just explain angioplasty for those that are not familiar with it or maybe not be in the world of, you know, medicine? If you could just explain that.
Absolutely. So they come to me with chest pain and I do an angiogram, which is putting the dye in the coronary arteries, and I find a blockage. So this blockage is preventing the blood from flowing into the heart muscle and supplying the muscle with the oxygen that it requires. So these blockages cause chest pain. And of course, when the blockage is 100%, you get a heart attack. And there, the muscle is completely deprived of oxygen and dies. So what I do is I specialized in putting a fine wire into the coronary artery, the artery in the heart, and then I would slide a little, it's like a spring, into the artery and open up that artery and then leave the spring behind. and then deflate the balloon, pull it out, and now the stent is left behind. So the stent is an angioplasty. Angioplasty means you're just basically fixing an artery or blockage. So that's what I would do. And Drew, the thing is that some patients did absolutely great, and others would come back with new blockages 6 months later, a year later, 2 years later. And I just couldn't understand it. And I looked at my traditional risk factors: smoking, high blood pressure, of course, diabetes. And then the list starts going blank. And I said, there must be more things that are causing this. And then that got me really curious. And then what happened is that I would have patients having heart attacks or angina, and then I would look at their risk factors and they don't have any. And I said, no, can't be. Why does this patient have hardening of the arteries? So then, this was about 20 years ago, I did a study here in my office where I took 100 patients in whom I did an angioplasty. And I said, how many of these people have diabetes? And I found that roughly a third of them had diabetes. But I did a glucose tolerance test on all of them in my office. It's a cheap test to run, so I did it. And I found that actually 80% of my patients had abnormal sugar metabolism. But yet only a third of them had a diagnosis of diabetes. So what happened to the other 1/3, or just over 1/3, is that they had an abnormality in their sugar metabolism. They didn't even know about it. And then I found that about 10% of them were actually diabetic, and they didn't even know they had diabetes. So there's a condition called glucose intolerance. That means your sugar level is a little high, but not high enough to make a diagnosis of diabetes. So I found that at least half of my patients in whom I didn't have a diagnosis of diabetes actually had slightly elevated sugar levels. And then that got me thinking that why is this happening? And right around that time, we were realizing that insulin levels are really high in these patients, and that type 2 diabetes is a case of hyperinsulinemia. So let me just explain that a little bit for the audience. So what happens is that in these patients, they develop high insulin levels, which keeps the sugar level down. So when you do the glucose tolerance, it doesn't look too bad. And you look at the blood test called a hemoglobin A1C, which is a test to see what your blood sugar has been doing over the last few weeks. They also stay nice and low. But the problem is the insulin level is so high. And I found that on my patients, that the insulin levels were so high for 10 years, 12 years before they become diabetic. So it's finally when the insulin just can't keep the sugar down, the sugar starts going up, you say, oh, now you have diabetes. But guess what? He's already had high insulin for by at least 10 to 12 years. And right then my curiosity really got there. I said, you know what? There's something going on here. And then as the more research came out and other researchers also came in, I realized that it's insulin resistance. And now, almost routinely, almost every patient gets an insulin level. Now, the problem is we were not doing insulin levels before. No one was measuring it. It was, if you go to your family doctor and say, I want to measure my insulin levels, he says, no, you don't need it. You just need a glucose tolerance test. And you do a glucose tolerance test, and it tells you nothing. It tells you that your sugars are okay, and you get a pat on the back and say, go home. But in reality, behind the scenes, you got this really high insulin level. So I think that this is a time when we need to be educating our medical profession also, that we need to be looking at the insulin levels, because I'm finding that when I find these high insulin levels and then I chase that and I bring it down through methodologies, which we'll talk about in a second, now I'm making an impact on those patients who have heart disease. And all of a sudden I started noticing the patients were getting better. When I bring their insulin levels down, and the way I brought it down, there's no magic pill to bring insulin levels down, as you know. There's no injection to bring your insulin level down. So that's when I got interested in fasting, because I realized, how am I going to bring this insulin level down? How am I going to? Okay, we're going to change the diet. Don't eat sugary things. Don't eat carbs. Don't eat simple stuff. But then as I started peeling that onion, I realized that it's not just that, it's also processed foods. It's also certain combinations of foods. And then I realized that, oh my God, we're eating too often as well. That's when I came and I said, you know what, there has to be one thing that'll help all of this, and that has to be fasting. Mm. And I looked at my insulin responses. It was fascinating that if you don't eat all day long and then have only one meal, you're going to make less insulin for that one meal than had you eaten that same meal after having had 2 previous meals that day. So what that tells me is that your sensitivity to insulin changes on a day-to-day basis, on hour-to-hour basis. So even your own circadian cycle, as you know, makes you insulin resistant at certain times of the day. Like when you're waking up in the morning, you're going to be a little bit more insulin resistant at that time, things like that. So as I read more and more, I got lost in this field. I said, oh my God, this is so amazing stuff. And how come we didn't do anything about this? So that's how I got into fasting. So you can see it was a little roundabout way that I got into fasting. Yeah.
It was a roundabout way, but really at each intersection, you're asking yourself, okay, what's deeper? Okay, what's deeper than this? Okay, what's deeper than this? And that's what brought you to a place of, wow, this one thing, this insulin, which plays so many different roles inside of the body, one of them being, keeping your blood sugar, down, is so central to all these conditions. You mentioned one, which is people having their arteries clogged. What are some other conditions, symptoms, issues, challenges that people are going through? Because often sometimes people hear this and they're like, well, I don't have any history of diabetes in my family. Okay, I might be a little bit more overweight, but I'm not having a diagnosis of diabetes. I'm not sure if this is something that I should pay attention to. But talk about all of the things that this is connected to beyond just diabetes, beyond just, somebody worrying about their arteries being clogged. What else is insulin and having too much of it in your body connected to?
So this insulin doesn't just affect the condition of your arteries in your heart, because ultimately, remember, when you're born, your that bud comes out of your heart, and then all the arteries grow out. The arteries in your heart grow out, and then the arteries, your aorta, your carotid arteries, and then down to your kidney arteries, your leg arteries. So these are all blood vessels. And what we've done in medicine is we've compartmentalized everything. And then we break it up into different organs. So we don't see that there's a universal connection. So if you have kidney disease, for example, well, what's wrong with your kidneys? Now, there are many different types of kidney disease, but the number one thing is still microvascular disease in your kidneys. So when you have high insulin levels, the tiny blood vessels in your kidneys are not going to work very well. They lose their ability to vasodilate. So insulin blocks nitric oxide production. Nitric oxide is a vasodilator, as you know. So when your nitric oxide is not there, you can't vasodilate. And the body is supposed to have this vasodilatory capacity. You're supposed to vasodilate and vasoconstrict. And you're supposed to have that flexibility. But you immobilize all your tiny blood vessels and capillaries when your insulin level is high. So in your kidneys, you're not going to get adequate kidney function. In the brain, you're not going to have adequate brain function. You're going to develop major arteries will also clog up your carotids, your peripheral vascular disease. So insulin affects every organ because every organ has blood supply, and you are as old as your blood supply. I mean, William Osler said that, right? You're as old as your arteries. So the manifestations of high insulin are widespread. So I'll give you an example. Some of my older patients coming in say, I'm getting a little demented, I'm getting very forgetful, and the spouse will say the same thing, and I will find hyperinsulinemia. And when I treat them and I change their diet, and I'm just the cardiologist, but I tell them, look, you got to do the following thing. The wife will come back and say, you know what, his memory is so much better now. He's functioning better. And we now know that when you do magnetic resonance imaging studies in the brain and look at functional studies, that it's the vasodilation, vasoconstriction that occurs in your brain, in different parts of your brain. And you basically immobilize all that when your insulin levels are high. And insulin is a growth factor. That's something else that people know. So how does it cause hardening of the arteries? Well, the walls of your arteries have smooth muscles. Okay, that's why they can vasoconstrict and vasodilate. And what insulin does is that it causes that smooth muscle proliferation. So it causes it to thicken. So the walls of the arteries become thicker as well. So it's a growth factor. It also causes left ventricular hypertrophy. Big word. Basically, the heart muscle, all muscles get a little fat when you put the patient on insulin or you have high insulin levels. So it's a growth factor. Growth factors also affect cancer and cancerous cells in the body. So a growth factor is something you want when you need it, but when you have an inappropriately high insulin level, you don't want those growth factors to be there. So take blood pressure. Now, Drew, I'm going to tell you something about blood pressure. Okay, I've been dealing with blood pressure since the day I graduated from school, and I was told that hypertension is essential. Well, there's no such thing as essential hypertension. There's always a cause for hypertension. And the number one cause that I have found in the last 10, 15 years, it's a hyperinsulinemia. So I'll give you a typical example. Young guy like you comes to the office, he's got no other problems. My blood pressure is high. I bet you got insulin resistance. And I measure his insulin levels, this guy high. Bring his insulin levels down, his blood. So now he says, well, my doctor told me I have to be on blood pressure medications forever. I was one of those doctors. That you have to be on blood pressure medicines forever. You can't come off this, you got hypertension. And I have realized that that's absolutely not true. If you find a patient who has essential hypertension, I now look for hyperinsulinemia. And invariably, I do find it, bring it down through dietary changes and lifestyle changes, and the blood pressures go away. And I've done that to hundreds and hundreds of patients in my office. So insulin causes hypertension because I just told you it vasoconstriction and it doesn't allow your blood vessels to dilate appropriately, and that causes hypertension. So when you look at metabolic syndrome, part of it is hypertension. And this is how it works. It's all because of hyperinsulinemia. So it causes hypertension. It causes hardening of the arteries in all your organs, and then you're going to feel the symptoms of that organ, whether it's your brain, your kidney, or your heart, or even your peripheral vasculature, or even endothelial dysfunction causing erectile dysfunction. So as a cardiologist, I don't see those patients, but my urology friends and I have now got this rapport going that, hey, you see those patients with erectile dysfunction, they have endothelial dysfunction. If they have endothelial dysfunction, there's something going on. You should be looking at the insulin levels. And it's been very exciting because we've actually restored endothelial dysfunction in these types of patients by appropriate dietary interventions and reducing the insulin. So you can see that it has ramifications beyond what we imagine, because it just depends which organ is being affected by the dysfunction due to happy. Am I peaceful? Do I have purpose? Do I have connection? Am I depressed? Because all these factors are also going to affect not only your eating habit, but also your general health. Let me give you an example. We look at the attributable risk of, let's say, hypertension or cholesterol to coronary artery disease. But have you looked at the attributable risk of things like depression? It's far worse. So if you're depressed, you're a sitting duck to have a heart attack. And nobody talks about that. They say, okay, let's look at your risk factors, or sit down here, tell me if you're depressed. You fill this form up and tell you if you're depressed. And nobody's got time to, your own family doctor doesn't have time to do that. And yet we don't realize that the attributable risk of depression and other psychological illnesses that you might actually have are far more. Do you feel connected? What's your understanding of your standing in society in general, or do you feel that you're at the bottom? Do you feel that you have confidence that you can talk with? All these things affect your physiology. So diet is one big part of it, but all these other things are so important. And I got to tell you about this one study, because this will really raise your curiosity on how I got involved with this. This was a study that was done at Johns Hopkins. They took medical students and obviously paid them for the experiment. You put an arterial line in their radial artery, and they were drawing out blood and putting it through a machine that measures your platelet reactivity. Okay, right? So they can tell moment to moment, because it's done through light, as to whether the platelets are aggregating or not. So platelets, as you know, are those tiny little particles that make your blood clot, make your blood sticky, which you don't want, because you want your arteries to be free flowing. So what happened is that they gave them a test while they're doing this, and they flip through the page, they answer the questions, and the platelets are happy. And then they turn the page, and now you got a question that on a subject that you were never taught. These kids go crazy now. Oh my God, I don't know the answer. And guess what happened to the platelet reactivity? Changed instantaneously. Wow. This is so fascinating that and I read the study about 30 years ago, and it stuck with me. But it showed me how your moment to moment, I'm not saying long, even moment to moment perception of stress affects your physiology. This is just one example. I've got hundreds of examples I can show you of how your mental state affects your physiology and how your body reacts on a moment-to-moment basis, down to even expression of angiotensin II receptors in your endothelium and your blood vessels. So whether you're going to actually clot right now or you're going to flow, and the number of receptors that are expressed we say that we have these angiotensin II receptors in our cells, right? Yeah? So we think they're fixed. They're not. 3/4 of them are involuted. They don't express themselves. Now, under certain circumstances, they'll all of a sudden express themselves. And that the stimulus for the expression of those receptors could be dietary, but more so, it can also be psychological, how you feel. And it's amazing to me that 50,000 receptors, now all of a sudden there are 100,000 expressing themselves. So now when the angiotensin comes along, you're going to get a hypertensive blood pressure response. Suddenly your blood pressure goes up. So we have these biochemical pathways, we know about it. But nobody's saying that, okay, fine, let's look at your diet, but also, come on, get a handle on your life. Let's decrease the stress levels. Let's do some meditation.
Let's look at the peer group that you're spending time with. Are they supporting you with their habits? There was a study that was an offshoot from the Framingham data, the Framingham Heart Study that was done in Massachusetts, that long longitudinal study. And the study's title was The Spread of Obesity Through Social Networks. And they weren't talking about Facebook and Instagram and that. They were talking about how we don't typically think of obesity as a contagious condition or a contagious makeup that somebody might have, but actually they found that when they looked at somebody in their life, if their best friend or there's somebody that was close to them that was a friend, even more so than their spouse, even more so than their parents or their siblings, if their close friend became obese, they were much more likely to become obese themselves. So this just goes back to the message that you're sharing, that when you step into this mindset of wanting to improve your life, feel better, and hopefully make the world a better place too, you start to look at every single aspect that's there and ask yourself, what is the nutrition that I need in that area of my life to feel whole, complete, and give back to the world? And in some cases, it's actual food nutrition. In some cases, it's healing your relationship. In some cases, there's so many people that are so alone today and don't have somebody that they would call a best friend, somebody that they can rely on, that can be their confidant. And every time I hear you speak, I'm just reminded of like how deeply connected all aspects of our life are. And we should feel happy about that, because even sometimes you have a week where you don't feel like you hit your fasting goals, or you didn't make as much progress in your dietary goals that are there, or you didn't get as good enough sleep. Okay, great. Don't beat yourself up. There's all these other areas. How about just calling a friend that you haven't talked to in a little while and making their day? How about doing something nice or kind for someone and feeling that joy that comes from giving back into the world, even if it's something really small? There's always something that you can do to take a step in the right direction of feeling better.
Oh, absolutely. So you see, now you're really talking about a holistic approach to this whole problem of chronic degenerative diseases, of which nutrition fasting is one part of it. But you just hit on so many important points about it's our whole lifestyle. The number of visitors that come see a patient after open heart surgery dictates how well that patient's going to recover. I mean, it's ridiculous. The complication rates are higher if that person has no visitors. What's that got to do with complications?
Wow.
Whereas if there's lots of visitors, I mean, these studies are all done. The number of visitors after open heart surgery to that dictates whether he's going to get home at day number 9 or whether he'll be discharged at day number 5. What's that got to do with it? So it gets really complicated. But it gets complicated. But then when you sit down and think about it, it makes sense. That you feel connected, your platelets are now pacified, your endothelium is working better, your blood pressure is better, your physiology is dictated by the chemicals you put in and the medicines and the food, which is your medicine, but also how you think, your brain and your whole psyche can also affect your entire physiology. So it's not just fasting. I mean, you can't be unhappy and fast. I mean, I think that's very bad. Um, and you mentioned something about the contagiousness of, this is definitely because behavior is contagious. That's why when you're trying to fast, you got to stay away from those enablers that enable you to break your fast and go back and fall off the bandwagon because your best buddy says, "Oh, come on, man, no, we're gonna go for a drink and we're gonna have some chips and et cetera, et cetera, et cetera." That's one thing, and the other thing is bacterial flora. So, it's amazing that your bacterial flora can dictate a lot of your physiology too. And I'm just digging into all this now, and I'm sure you're aware that you can do fecal transplants from an obese person to a thin person and vice versa, and you can actually change physiology. And this data is just coming out, and it's fascinating. But again, I tell my patients, look, that may be true. Just take care of your own flora. Feed them the right things. Give your gut a break. Let the bacteria flourish, the good ones, because the bad bugs have a short half-life. That means if you don't eat for 6 to 8 hours, you've knocked off some of the bad bacteria in your gut. So the good ones are the ones that are going to stay behind, and they're going to be your resident population. So I said, feed them the right thing. Eat according to our program over here, and you'll have the right bacteria. Then you won't have to talk about fecal transplants and capsules and all these things that they talk about these days. It's absolutely fascinating stuff.
It's so true. And also, too, when you get a craving, you have to think, we don't have the ability to distinguish it now, but is that you, or is that the quote unquote wrong bacteria that's having that craving? The yeast inside of the body, the candida, the buildup of different funguses, other things like that are in the gut that are craving because they feed off of these sugars. And those signaling molecules, those modulation of the gut bacteria can drive your own craving that's there. So sometimes it's not even you that's craving it. Sometimes it's your bacteria, and maybe not the type of bacteria that we want to continue to grow further.
Oh, you are so astute. You hit on that gut brain axis connection, and it's so true. And I just want to leave you with one word about that. That is that almost 50 or 60% of the micronutrients that are floating around in my bloodstream and your bloodstream are not what we ate. It's what the bacteria made and liberated them as a gift to you because you harbored them and you fed them the right stuff, hopefully, and the right kinds are there, and they now float in your body. So if you look at turmeric, which our ancestry uses, and we say, oh, it's an antioxidant and all that. Well, actually, it works in different ways. And similarly, there are many others that actually the bacteria, the polyphenols are taken up by the bacteria, and they utilize those and then release the final chemicals into your body. It's not the polyphenols getting into your bloodstream. So you're eating for yourself, and you got to do the fasting, all this stuff, but you're also eating for your bacteria. And your bacteria in turn are producing tons and tons of chemicals that are then liberated into your bloodstream. So you just hit onto a huge thing right there. And, we can talk about hours and hours about all this wonderful new stuff we're learning. It's just amazing. Amazing.
Yeah, it's so amazing. I have a couple more questions, and I want you to just be able to share about your world a little bit and just anything that you want to have. If you had to ask for our audience, to check out something that you're up to, then I'd love to get to that. So selfish question that I'd love to ask you, I wear a continuous glucose monitor, and that's been amazing. I was one of those people that I was always more on the thin side, but I even noticed that even in my college career, growing up vegetarian, everything, I started even as thin as I was and quite skinny at the time, because I was vegan. I actually became vegan after that. After being vegetarian, I started to get a little bit of the belly. So I was that tofu. I was that, thin on the outside, fat on the inside, and I had that belly fat. Then I got into the world of functional medicine, other things, tried a bunch of different stuff, started incorporating back in super high quality animal foods into my diet. Completely a game changer, especially I tested my omega-6 to omega-3 ratio using Omega Quant. It's a test that's out there that's pretty popular. No affiliation. And I saw that my omega-6 was really high and my omega-3 was really low. So I started incorporating high quality fish into my diet. salmon, wild-caught salmon, other things. And I felt like a completely different person mentally. Like I was turned on. I wasn't clinically depressed before, but I was feeling like I wasn't as sharp and I didn't feel like that luster for life. So that evolved into, as keto became a little bit more popular, I said, you know what? Let me try this on. Now, I found through my experimentation of keto and I eating lower sugar, lower carbs in the diet that was there, that I fall into what looked like this smaller classification of people that has loosely been called like lean mass hyper responders. Those are people who their lipids, a lot of people go on a higher saturated fat diet and their lipids improve, like a lot of the patients you worked with. I went on that, even though I wasn't having the sugar and other things, and my markers, my LDL, my NMR profile breakdown of my small dense, they went in the wrong, like in the not the great direction. Have you worked at all with patients like that are in that category that might signal that, generally that type of diet works well for a lot of people and probably most people that are following the Western diet, but there could be either a phenotype or a genotype component where people don't do as well on that diet? Would love to hear any thoughts that you have.
So I think you hit on a number of good points over there. Number one is we are very variable in the way we respond to foods as well. So wearing the glucose monitor, you'll notice that somebody else eats that same meal. Their sugar response is different and yours is different. So, and different foods create a different rise in your glucose. So we are all a little bit different. So you need to find your food profile that best suits your glucose rise. So after experimenting with your diet to see which of your foods cause the greatest sugar rise in your bloodstream, you can't then take that and give it to everybody because they may react a little bit differently. So to a certain degree, what you've done is very unique because you've done a unique examination of your own sugars. So we all tend to respond a little bit differently. So I think that's a very important point. And then the other thing is that your lipids, for example, how they responded. Generally speaking, when I put my patients on a moderate fat, no sugar, moderate protein diet, the LDLs do go up, exactly like yours did. But what I find a little surprising with you is you said you had small dense particles. They go up, but they're usually large fluffy particles. So when your LDL particles become small, this is the take-home message. That means that no matter what you're doing, it may be helping you in other ways, but there may be some inflammation going on. Because when the LDL particle, how does it become small dense? It becomes small dense because lipopolysaccharides from your gut are actually getting in and they displace the cholesterol from the LDL particle and now create a small dense particle. That small dense particle also is more likely to get oxidized. So these small dense particles, you don't want them because they're more oxidized. So it tells you that you got lipopolysaccharides, which is endotoxin, getting into your bloodstream. So then you got to ask yourself, well, why is that happening? And it may be that there's certain foods that may not be causing symptoms in you, but may be causing a breach in your gut barrier. That may be because you got to ask yourself where this inflammation came from. And that's the $1 million question I asked every professor when I was doing my fellowship. Where does this inflammation come from? Nobody had an answer. Not a single professor had an answer. And it's plagued me all my life. Where does this inflammation? It comes from the gut. It comes from the gut.
It's so interesting that you said that because we had a microbiologist on the podcast. His name is Kiran Krishnan, and he's with a company called Microbiome Labs. And he had suggested to me, because I had talked about this early on, that I said I had a relapse of some skin irritation and acne. And he said, you know what, for some people that had a history of leaky gut, and I had a lot of antibiotics usage when I was a kid for sore throat, other things, and I'd suffer from leaky gut. In some instances, higher saturated fats, even though they can be a lot of beneficial, like butter, ghee, coconut oil, they actually, if your leaky gut isn't fixed, they cause an endotoxemia effect. So I removed coconut oil from my diet. I removed the higher saturated fat foods, even though I love, grass-fed beef, and I think, I generally recommend it for people. And I noticed a cooling of the inflammation. My skin irritation went away and it kind of brought down. And now I'm doing an updated gut protocol to heal all that. In the meantime, I've eased up on some of those foods personally, again, just for my own life, to cool that inflammation for me. But it just goes to show you that there's so many layers that are there. Generally speaking, everything that we talked about in this interview is largely going to work for people that are there, but we're all on our own unique journey of figuring things out.
Exactly. So we knew that you've got small dense particles, lipopolysaccharides get. How do they get in? They get in through the leaky gut. What is the mechanism? What's the carrier molecule? The carrier molecule is saturated fat. So we do know that the more saturated fat you consume, and if you have a leaky gut, now those saturated fats will take endotoxin or lipopolysaccharides into your bloodstream and now cause small dense particles. So you got to work this out. So you're absolutely right. So working out this chemistry is very important. And everyone's individual. So say, okay, you did this, you did this, you did this. But now you got this. But what else can cause this? So you got to think this. Now, look, I'm a simple cardiologist. I'm not a gut doctor. No, am I? But you know.
But you know more than most gut doctors that are out there. Just saying.
I just, you know, it's fascinating to me. And it's very humbling that all this is going on, and we need lots more researchers and we need people like you to let people know that, look, it's complicated, but it can be done. Like how you worked it out. You said you still have a leaky gut. Okay, fine. And the saturated fats are the mechanism by which the lipopolysaccharides get in. So you got to look to see which foods may be causing your leaky gut and how can you get rid of that. So again, you know, that gets really complicated, and people do tests in the bloodstream to see which antibodies are there and which foods might be causing it, because you may not have overt GI symptoms, but you may have certain food intolerances, especially wheat products. So what I do in my practice as a general rule, when I'm suspecting that there's this gut issue going on, I just have to stay away from wheat, because that's the number one problem I've found. And when I do that, honestly, for 80% of the patients, it helps my situation. They may not come back and say, oh, my bowels feel great, but I know that I've helped them because I see the markers in their bloodstream and other things, their weight and everything else, I see it. So wheat is a big one, especially processed wheat, you know, and it's all processed. It's all made into powder. Wheat is number one. And then, of course, some people don't tolerate dairy products, but I do an elimination, a simple elimination. Look, right now, just get rid of all wheat. Just get rid of all wheat. And then if you're going to eat other substances, I do believe that you need to be careful about some lectins, because I tell them to soak the food, the lectin-containing foods, and then use a pressure cooker to kill them. So I teach them a little bit about how to eat right. And then I look and see what's happening. So, you know, with a leaky gut, it gets a little complicated, but yeah, an elimination diet before I do blood tests, because otherwise there's so many blood tests.
It's so true. And even just practicing, because, and there's been a lot of people that have talked about this, even just incorporating fasting. Fasting is one of those mechanisms that supports your body in repairing that gut lining when you take a break. So even taking it full circle, fasting can play a central role in helping you to address that leaky gut in the first place. And we'll link to a few resources that are out there. Dr. J, I want to be honoring of your time. I'm sure you have patients and other stuff and things to get into. Tell us a little bit about your world. You know, I came across these viral videos of you on YouTube that you gave as a lecture to, I forgot the institute's name. Can you remind me?
Yeah, it was Florida Hospital, which is now known as Advent Health, the big hospital right here in Orlando.
I saw those. Yeah. Immediately I reached out to your office and I said, I gotta get Dr. J on the podcast. You know, since you putting out this content and it being out there in the world and getting such a great response, tell us what you're up to. You know, you're seeing patients. I mean, after this interview, I know some people are going to ask, like, can I work with them as a doctor? You know, what's going on in your world? Are you thinking about writing a book? Because I think a lot of people would be very interested. Yeah. Just tell us a little bit about your world.
I'm still a day-to-day cardiologist. I still see patients every day, and I do my procedures. I do pacemakers, ICDs, and I do all this stuff. I do angioplasty. But I have a full, fantastic staff. So I have a bunch of nurse practitioners and PAs that I have trained to address these issues with my patients. And those who are the toughest ones, then I do still see them. So I am a regular practicing physician. I'm creating new slides. I'm going to do another video on food addiction, because I really think that that's a huge problem, how to overcome food addictions. So I'm going to do that one. And then the South Asian paradox, and I'm going to make another series on that. So again, more education. A book, it's so hard to find more hours in the day to do that. Although I've been told that I should, it's hard. It's hard to do. But hopefully in the future, I do want to do that. But on another note, I am going to open another wing of my practice, which is going to be for lifestyle and medicine, where I will see patients personally for a longer period of time. I can sit with them for 1 hour. And then the next visit will be with a nurse practitioner or the nutritionist, and then have a nutritionist in the office. I'm looking to build that. So I'm not ready for that yet, but I'm building that because I think this is badly needed. But in the meantime, if people watch these videos and they make changes, because I get so many emails that we've never seen you, we live in some part of the country, and you've made a great difference in my life. And to me, that's very rewarding because I'm not seeing you, and yet I'm able to touch many lives, just like you. You have improved thousands of people's lives through the content of your talks, and I think that speaks great for this new platform that you've created, and this internet that we now have with YouTube and everything. So we'll continue to do this, and we're going to cross paths. I'd love to meet with you again in the future and tell you about the new things that I'm doing, which is really the gut bacteria. Oh my God, Drew, I've read 4 books on the gut bacteria lately. I am so excited about it, and
so
as you
excited
know,
about that
how
topic
the
too.
TMAO and how that all links in with atherosclerosis. I'm finally beginning to answer or get a glimpses of questions that I asked my professors for years and years and years. So I think the future is going to be, we'll talk more about the gut microbiome. And if there's one thing I'm going to leave you with, it's that I think that there's a lot there. I think it's all going to, a lot is going to come down to the microbiome. So that is the